All right. So I always talk about the normal because you have to know normal to know abnormal. That's important to me. It's easy to memorize things, and when you memorize, you forget, and then you freak out on the test. But if you can work through it, that's how you're going to know it. So this is your normal. We've got the alveoli right here, correct? Right here, the alveoli. What is this right here? Yeah. It's pulmonary artery, right? So those pulmonary arteries, where is that coming from? It's coming from the heart, right? The right ventricle. That's the whole point. So you've got deoxygenated blood that's coming from the pulmonary artery, from the right ventricle, and it passes through all these little capillaries. So I'm just showing you one picture, but this is happening in hundreds of spots all over your lungs, right? And as it's passing through, it's giving off the CO2. Because what do we do with CO2? We blow it off, right? So we're giving that the deoxygenated blood is giving the CO2 to the lungs to blow off. And the O2 that we've breathed in is being given to go ahead to go where? Pulmonary vein. Good. To feed the left atrium, the left side of the heart, right? It's pretty simple, but everybody got that? So why do we have respiratory failure then? Well, it's some kind of inadequate gas exchange. So we're supposed to be giving CO2 and receiving O2. So either we're not getting enough O2 or we're retaining too much CO2. So if you're retaining CO2, right, if that artery is passing through and it's keeping the CO2 instead of blowing it off, can O2 be absorbed? No, because it's kind of like a cup of water. You can only have so much in your cup of water. And if you've got it full of CO2, then you can't accept any more O2. So this results in some kind of inability for the lungs to meet the O2 demands of the tissues. What happens if tissues don't get O2? They die off, right? A lot of what we talk about in test 3, sorry y'all, is that these are all conditions. They are not diseases in of themselves. So when we talk about ARDS, when we talk about MODS, when we talk about SIRS, when we talk about DIC, they're not a disease process themselves. They are a condition or a symptom of something else happening. So if that's the case, how do we treat ARDS and MODS and SIRS and respiratory failure? What is it, Amanda? We're not treating because this is a symptom. Treat the underlying cause, right? Treat whatever's causing it. So that's going to be really important to know. Because again, is your patient going to sit there and tell you, I'm in MODS? No. You're going to have to recognize these are the symptoms of MODS. I know that this is a condition. Something's causing it. In order for me to stop the symptoms, I have to treat what's going on. So when we have failure, we said it's too little O2 or too much CO2. So hypoxemic is an oxygenation failure. Too little O2. And what's important is that this is in despite of supplemental O2. So no matter how much O2 we throw at them, they're still not going. So you can put that nasal cannula on. You can put that non-rebreather. They're having an issue with low O2 despite you giving it to them. If it's hypercapnic, it's a ventilator failure. For whatever reason, we're not blowing off the CO2, right? So too much CO2, and the body can't compensate. We'll talk about this in ABGs, but what happens to your pH when you retain all that CO2? Goes down, which is what? Acidic, right? Okay. No compensate. Okay. So this is hypoxemic, right? We said there's hypoxemic and there's hypercapnia. This is a hypoxemic issue. We're going to talk about the VQ mismatch. Right here in the middle, this is normal. This is what we talked about right in the beginning. Non-oxygenated blood comes in, it gives the lungs CO2, it gets O2, and sends blood back to the heart to send out to the body. That's normal. That VQ mismatch is 1-to-1, meaning that the air, the ventilation equals the blood perfusion. 1-to-1. That's what we want, VQ mismatch. Ventilation equals blood perfusion, right? So we ventilate O2 and we're perfusing blood at the same time, right? We're having that exchange. So, oh, there it is, right there. Air equals blood flow. And we want that to be, oh, my shoe just came off. 1. So normal, right there at the bottom, we've got normal. We can have either a ventilation problem or a perfusion problem, right? Because we're exchanging oxygen. So over here, you see that we have a ventilation problem. This is an absolute shunt. There is a big old mucus plug. So blood is working fine. Blood's coming through. Blood's saying, hey, I've got this CO2. Let me give it to you. Let me get some oxygen. But because of this big old mucus plug, oxygen can't get through mucus, right? So oxygen can't get through that mucus. CO2 can't get through. So there's absolutely no exchange happening. So do you see why now when we're giving O2, we keep throwing O2 at them? Does it matter how much O2 we're giving? No, because it can't get through at all. It's an absolute shunt. Now you can have some conditions where it's kind of in between, like right here where there's like some secretions, so not as much exchange. So you have a decreased ventilation, decreased VQ mismatch, because the V is ventilation, right? And it's kind of this pendulum that swings back and forth. So right now I can go just from a little bit of shunting to total shunting. And it's all because something's going on with my lungs. So if this is respiratory failure, this is a condition of something like, well, we're going to talk about ARDS or some kind of disease process that increases your secretions. Once we treat those secretions, so as a nurse, what are your priority interventions going to be? To treat secretions, to suction, to do CPT. Are you going to keep throwing O2 at them? No, because you know the patho right here that says that's not going to help. So decreased ventilation, secondary secretions, swinging that pendulum all the way to an absolute shunt where there's no ventilation because there's some kind of mucus plug or fluid. On the other end, you can have your lungs working fine. They can be taking nice deep breaths. There's no mucus. There's no issues here, right? We don't see any secretions. But for some reason, there's either a clot or something that's blocking the capillaries. So the blood can't get through to do the exchange. You're ventilating. You're giving oxygen. So again, can you throw oxygen at this person all day long? You can. Is it going to help? No, because they can't have that exchange here. There's some kind of clot that's blocking it. So it doesn't matter. You can give them all the oxygen you want. But if the blood can't get through to receive that oxygen, it's not going to make a difference. And then right here we have dead space, where there's a total clot. Blood's not circulating at all. Some kind of obstruction of the pulmonary capillary. So when we talk about these extreme VQ mismatches, over here, when we talk about this dead space, that's like a VSD, like little babies have. That's why they get blue, because they're not having that exchange at all. They're not passing through the capillaries to begin with. Or over here, when we talked about the plug, that's what we're going to talk about ARDS. So these are all going to be respiratory type issues, right? COPD, pneumonia, asthma, atelectasis, pulmonary embolism is going to be more on your perfusion side. They're all going to be reasons why you can't have that normal ventilation perfusion. Oh, pain too. Is the red better than the pink from last year? No. I redid it too, because last year it was pink and you couldn't see it all. Second one is pneumonia, asthma. Well, think about any kind of respiratory issue that you're going to have mucus production. All these things, COPD, pneumonia, asthma, atelectasis. PE is a pulmonary embolism. I'm going to have to pick a different color next semester. Okay. Yeah.
That side's better.
Oh. I don't know. We can turn the lights out then. Make it ambiance.
This one's like neon.
Probably the lights.
I don't know. I'm afraid if I turn the lights off, you're all going to go to bed.
No, we all got sleep last night.
Yes, it's better.
I don't know if I can handle that. I'm sorry. I'll be up there napping. All right. So, again, this is a hypoxemic issue. When we talk about diffuse limitation, and we are just briefly touching on this. This is basically what we were talking about in the last slide, but it helps relate to ARDS. So you have a thickened or damaged alveolar membrane, right? So this is the membrane right here. You saw it in the last slide where it was nice and smooth. This is thick. Imagine like, I don't know, like someone doing karate. Is it much easier for them to like chop a piece of paper versus a piece of wood? Right? Because it's thinner, easier, more pliable. Same thing with our alveoli. They should be thin and, you know, have that equal gas exchange. When it gets thick, it's harder to do it. Again, it's all the things we talked. Ooh, I'm sorry. It's all the things we talked about. COPD, pulmonary embolism, and we're going to talk about ARDS. But this is all hypoxemic reasons. We're not getting oxygen. And we're not getting that oxygen either because the lungs aren't giving it or the blood won't allow it. Does that make sense to everyone? Yes? No?
Can you say it again? Lung.
So it's a hypoxemic, low oxygen. It's either because the lungs can't ventilate or because the blood's not perfusing. You have to have that exchange. You have to be equal. And for whatever reason, on the lung end or the blood end, it's not happening. That's different than hypercapnia. Hypercapnia is increased CO2. There's some kind of imbalance with the supply and the demand. So ventilator supply should equal ventilation demand. Basically breathing in and out. You should breathe in as much O2 as you let out CO2. Does that make sense? All right. So for whatever reason, your supply, the oxygen you breathe in, is not equal to or less than the demand of the body because you're not blowing it out. Normally, we have a lot more supply than we do demand. So what are some things? Airway alveoli abnormalities. What are some reasons, airway problems that you can think of that you've learned in nursing school that you would have basically air trapping? You're not blowing off CO2. Asthma, right? Those airways clamp down and you can't blow off the CO2. What's something else? COPD from cigarettes, yeah. What else? CF, okay. All those reasons, your airways are trapping air. So if you have some kind of airway abnormality where you trap air, you're not blowing off the CO2. What about any CNS abnormalities? Overdose, right? Your head trauma patients. What happens to their respiratory rate when you overdose or get head trauma? What does it do? Plummets, right? So if your respiratory rate goes down, are you blowing off CO2? No. These are your brain injuries, your spinal cord injuries sometimes can have this issue. Chest wall abnormalities. So those who, be honest here, those who listened to the lectures last night, they talked about the flail chest, right? So with the flail chest, there's a piece, a segment of ribs that are not, they're like totally disconnected and they go opposite of what normally. They have that paradoxal movement. They can't ventilate. So if you're not ventilating correctly because you have some kind of chest wall abnormality or, rib cage abnormality. What about those like Marfan's or some of those other disease states that their chest wall is super tiny? Can they get that expansion like they should? Any neuromuscular conditions? What can you think of neuromuscular?
ALS.
Yeah, ALS, MS, tetraplegia, yeah. Anything, again, so these are all things where what happens to your ventilation? What happens to your respiratory rate? It goes down. So you can't breathe off that CO2. If you're not breathing off the CO2, you're not able to accept O2. So nothing's wrong with your lungs. Nothing's wrong with your perfusion. It's not a hypoxemic issue. If you could get the oxygen, your blood and lungs would work fine. But for some reason, you're not. So again, is your patient, or is a test question going to say you have a hypoxemic patient? No, they're just going to tell you patient was involved in an MVA and they got head trauma and their respiratory rate is this and their pH is this, and you're going to go, oh crap, they're not breathing, they had a head injury, their respiratory rate's low. How do I treat that? Is oxygen going to help increase respirations? No. Okay. What is going to help? Okay, so but they have head trauma and they've got low O2 right now because they're not breathing. Oh, we can intubate. Do we need to help them breathe? Yes. So this is how you guys should be thinking. I've got to fix the problem. If the problem is, so this is why we don't memorize. This is why we have to understand normal. If the problem is I've got low ventilations, I've got to increase ventilations and treat that cause, right? So how do I increase ventilations? I have to breathe for them maybe. Huh? Not always. Sometimes it's just about increasing the ventilations. We're going to talk about positive PEEP in just a second, but that helps more with like your hypoxemic issues. All right, so this is table 68-2. I believe it's still page 1658. I may be a big fat liar. I don't know. It's in your book. And I'm just going to put it all up there. It's a bunch of different stuff. It's all in your book. So don't freak out about writing it all down. Just think it through. What are signs? So what's the first thing we always see when we have decreased oxygen? Changes in mental status. Does this just mean that they're like in a coma? No, they could just be agitated. They could be restless, like, I can't get enough air. They're a little anxious, right? Those are all changes in their mental status because it's kind of scary when you don't get enough air. A lot of times they can have a morning headache. Why do you think they have a morning headache? Yeah, what happens at night to your respiratory rate? It goes down, right? That's normal for us, but for someone who already has an underlying issue, if their respiratory rate goes down even more at night, they're going to retain CO2. Retained CO2 gives me a headache. Early signs and symptoms, their heart rate can go up a little bit. They might try to compensate by increasing their respiratory rate. Late signs are cyanosis. So that's why you can't wait for your patient to be blue to understand that there's a respiratory issue. If you have waited for them to be blue, you've waited too long. They might do that rapid shallow breathing, like so they can blow off the O2. You might want to ask them about orthopnea. What is that? The number of pillows, right? So if when you're doing a history, you're asking things. How many pillows do you use at night to sleep? Do you need like 4 pillows? Do you sleep in a recliner? They might tripod a lot, like when they're sitting, because it helps open up that AP diameter. They may not be able to speak. A lot of times you can see what kind of distress they're in by how well they're able to hold a conversation with you. When you have a patient come in and you're like, what happened? I got hit. If they're speaking like that, they're having trouble catching their breath. Retractions, change in the inspiration, expirations, change in the IE ratio. It's going to be increased. Normally we have expiration that's twice as long as inspiration. Right? So if it's prolonged anymore, what do you think they're trying to do? If it's, they're blowing off that CO2. Their body's compensating. Your body will figure it out and say, I've got too much CO2. I don't have enough oxygen. What can I do? But it's only going to compensate for so long before it crashes. And they're going to have hypoxemia. We want their PaO2, which is basically your blood gas, to be greater than 80. So hypoxemia is when the PaO2 is less than 80. Hypoxia is when you have less than 80 in signs and symptoms. So that's when you start developing, that says metabolic acidosis, decreased cardiac output, decreased renal perfusion. So there's a difference between, a lot of people use those words interchangeably, but hypoxemia is actually just a PaO2 of less than 80. Hypoxia is when the PaO2 gets low enough that you have signs and symptoms. So I'm going to put them all up there. Diagnostic studies. Obviously, H&P is really important, right? We're going to ask them questions about how they sleep, how much activity they can get. You know, do they have a headache in the morning? ABGs are very helpful. Shows us the pH, if they're having any respiratory acidosis because they're retaining too much CO2. Chest x-ray. Cultures, they help if we think that there's some kind of a pneumonia or infection that's causing it. You can do a VQ lung scan, a pulmonary artery catheter. I'm going through these quick. I'm going to move on. Don't freak. And what's our goal? We want ABGs within normal. We want breath sounds within normal limits. Most importantly, we want them to have an independent airway, right? And we want them to be able to cough and clear any secretions. So if these are my goals, oh, I think I hear a care plan coming out. If these are my goals, my interventions are going to be this to meet my goals. Which one?
Breath sound, yes.
Breath sounds, BS. You know, what we teach you. No, just kidding. Breath sounds. So let's look at this. If our primary goal for respiratory is to correct the hypoxemia, we're going to give oxygen that's tolerated by the patient. We want the PaO2 to be above 60, the SaO2, your pulse ox, to be above 90, and we want it at the lowest concentration possible. So are we going to put oxygen on them and crank it up to like 10 liters? And we're like, well, they're good. They're satting 99%. No, you want to give them the least amount of oxygen to create the best respiratory effort. Respiratory, we also want to mobilize any secretions. If this is a hypoxemic issue, because they've got some kind of shunting going on or some kind of increased secretions, hydration, right? The more water they intake, IV fluids we give them, the thinner those secretions are going to be. CPT, everybody remember CPT? The chest physiotherapy where they bang on the chest. That helps loosens the secretion so a patient can cough them out. Suctioning. And we're going to talk in a second. We don't want to go crazy with the suctioning, but suctioning helps. Teaching them to cough. And then there's positive pressure ventilation and non-invasive positive pressure. We're going to get into that with our vent lecture in just a second. Well, maybe more than a second, but in just a bit. So again, this is not a disease in itself. We can't treat, per se, respiratory failure. We have to treat the symptoms and treat the cause. So drug therapy, bronchodilators. What do bronchodilators do? What? They open it up, right, by helping decreasing the spasms. If you think about it, you have, your airways are like, let's just pretend these are your airways. You have little muscles that are surrounding the airways like that. What's happening in disease processes like asthma, COPD, you not only have all this mucus building up, but those muscles are clamping down. So bronchodilators stop those muscles from clamping down. Corticosteroids, they're going to help decrease all this inflammation that you've got right here. Diuretics, right? If you've got too much fluid overload, if you have that absolute shunt, that's why we worry about overloading the heart and too much fluid, and that's why we hear those crackles and everything in the lungs, because those alveoli are filling up with fluid. If those alveoli are filling up with fluid, are they able to have any O2 exchange? No. IV antibiotics, if we're thinking that this is a pneumonia, some kind of infection. They may need benzos or opiates if they're in any kind of pain, right? Because what happens when we're in pain, what do? We kind of clamp down. So is that going to be a hypoxemic pulmonary issue? Yeah. Benzo, opiates. And obviously we want to treat the underlying cause. Why we're providing symptomatic care. Why we're saying, oh, my head trauma just got hit in the head. They have a decrease. They have a ventilatory problem. They're not ventilating. They're not breathing out. I'm providing supportive care by venting them, by increasing their respirations. But in the meantime, the only way to get rid of the problem is to treat it. So I provide symptomatic care by treating the issue, treating the underlying cause. And it's really important that we maintain cardiac output. Why do we want to maintain cardiac output? Oxygen supply, right? And this is all going to lead, we're going to talk about ARDS, and then this is what leads to shock and SIRS and MODS. Nutrition, always optimal method of feeding. Do you think that these patients that are in respiratory distress, are they going to have like nice, healthy stomachs, or are they going to develop ulcers? You think that's going to help the issues or make it worse? Make it worse. So we want to feed them as early as possible by the best way possible. Now, if they can barely speak and they're using 20 pillows to sit up, maybe they can't eat enough by mouth, so we need to provide nutritional supplements. If they're vented, they may need an NG tube. We keep going down the line. Best way to feed them is by mouth. Then we might have to do like NG feeds. Then we may have to do TPN. Always start out with the best way and move our way down, but we need to provide some kind of nutrition. So you have to see what's appropriate for your patient. They need a lot of protein and calories, and they need supplements. And again, these are all our expected outcomes. We want them to have a good airway, patent airway. We want them to be able to remove their own secretions. They need to have normal respiratory rate, normal breath sounds, adequate O2 by a normal ABG, normal hemodynamics. We want them to be normal, right? You could just write normal there if you want to save some writing. We want them to get back to their baseline. All right. Does anyone have any questions about respiratory failure? Does everyone understand the difference between hypoxemic and hypercapnia? If you don't, please let me know before we move on. Yeah. So you have respiratory failure either because of a hypoxemic issue or a hypercapnia issue. So way back in the beginning, we said it's either because of too little O2, so hypoxemic, or too much CO2. And that's either because we have this mismatch going on, right? Either we have some kind of blockage where oxygen can't get through to the blood, or we have some kind of blockage in the capillaries where ventilation's happening but blood's not going through. That's a hypoxemic issue. In contrast, you have some kind of hypercapnia where basically you're not blowing off CO2. And you're not blowing off CO2 because either you can't because your airways are clamping down on you, or because you had a head injury or you took too much drugs and you just decreased your respiratory rate, or because you have a flailed chest, or because you have muscular dystrophy, or for any reason you just can't blow off the CO2. Mm-hmm. Yeah. And from like what end it is, like is the ventilation working good, is the perfusion working good, or what's not. But you can see that on chest x-ray. Because you'll see white, because what should you see on a chest x-ray? Black, right? If you see any white, there's fluid in there. And that's why you do, and so you're not just doing, you never just do one test. That's why we get the history and physical, and that's why we get like an ABG and a culture and a chest x-ray, because then we put those pieces together and say their white count's high from my CBC and their culture came back growing, you know, acid bacillus, and their chest x-ray shows some whited out in the left lower lung. So I'm going to assume they're not ventilating properly because they have a pneumonia in the left lower lung. And I know that this organism is sensitive to this drug we're going to treat with those antibiotics. And in the meantime, I'm treating that cause. I'm going to be helping my patient. Am I going to be just blowing O2 at them, helping? No, because I know that that's not the issue there. So what I would be doing is providing CPT. I would be suctioning. I would be helping them take deep breaths. I would be helping them cough, because that's the underlying issue. That's going to be different than your hypercapnia patient, like we talked about, the drug overdose or the head trauma patient. The way I help them is, again, not to throw oxygen at them, because is that the issue? No, the issue is that they're not breathing off that CO2. So that's why it's really important for you guys to understand, not just memorize these conditions, but understand what's going on, because that's going to determine how you treat your patient. So what signs and symptoms is my patient showing me, and what clues in their history is telling me why they're having those signs and symptoms, because that's how I'm going to treat them. Does that make sense? All right. All right, any other questions? All right. Basically ventilation, because you want to help them increase their respiratory rate. Now, if it's a drug overdose, you could give them something to counteract the drug overdose. If it's a head trauma, why do you think the respiratory rate goes down? Because of increased ICP, right? So we're treating ICP. But if it's like something like a muscular dystrophy or that, you just have to help them with ventilation because they can't do it. If it's a flail chest, then you're treating the flail chest. But most of the time, if it's a hypercapnia issue, you're increasing ventilation, right? Because it's a ventilatory problem. You have to blow off that CO2. These are good questions, so please don't hesitate to ask. Anybody else? Yes.
So with
That's okay.
Get myself together. So with the hypoxemic patients, it goes into the vent, and then it like kind of like an umbrella, and then that goes.
Hypoxemic is the umbrella for perfusion or like ventilation.
Okay.
And that's different than your hypercapnia, which is just kind of a breathing issue, a ventilate, you know.
And with a patient, so like say somebody with asthma, their thing would just be like a bronchodilator.
Yeah.
Open that up.
Because
So
they're
that
trapping
just,
air, right?
So that
So-
would just be what
Mhm.
we do. Obviously, you wouldn't intubate somebody with
Nope.
asthma.
No, unless, I mean, sometimes we do if it's really bad.
Yeah.
But if they're decompensating, because remember, your body will compensate for so long, and then it says, okay, I'm done. I've tried hard enough. So, yeah, with asthma, that's why it's really important to look at cues from your patient, know your patient's history. This is why I get my poor group, I'm sorry. I get on you for that S-bar, why I want to know the situation, why I want to know the background, because that's going to paint the picture of how I'm going to treat my patient. Okay? Yes?
Did you say something about hypoxia versus hypoxemia?
Mm-hmm. So there's, right here, in the green, clinical manifestations. Hypoxemia is just a PaO2 of less than 80. Hypoxia is a PaO2 that's low, typically lower than 60, that has signs and symptoms. So just because your PaO2 is low, it might just be your body's compensating. This is your time to intervene. You may not have any obvious signs and symptoms. You may not be in acidosis. You may not have decreased cardiac output. But, so, people use them interchangeably a lot, but they technically are different.
Quickly, so one is just hypoxia, is just a deeper degree of hypoxia, would you say?
Hypoxia
Yeah.
is when you have hypoxemia that has, gone basically bad,
Right.
and you starts developing signs and symptoms. All right. Any other questions? All right. So ARDS is an acute respiratory distress syndrome. This is a sudden progressive form of acute respiratory failure. So it's everything that we were talking about. Those alveoli, remember when I showed you the diffuse limitation? That's why I showed it to you. Those alveoli that should be nice and thin and pliable. They fill up with fluid. So you have that absolute shunt happening. And this results, and we're going to talk about it in depth, so if you don't want to write all this down, but this results in severe dyspnea, hypoxia, the lung is not compliant, right? Because how do the lungs open and close? How do those alveoli open and close? What do they need? Starts with an S. Surfactant. Oh, brown sugar. Right? They need surfactant, okay? So, but with this, because the alveoli are so, think of a water balloon that you fill up. If you fill it up a little bit, is that water balloon still nice and like squishy and kind of bouncy, right? What happens if you fill that water balloon way too much and it's stretched really, big? It's going to burst, but does it have as much compliance? Right? It doesn't move the same way. And we're going to talk about this PF ratio. So if you guys heard of a PF ratio, you've seen it on charts, and you're like, I don't know what that means. So a normal PF ratio, we talked about the PaO2. We want it greater than 80, right? So a normal PF ratio, you have a PaO2 of anywhere from like 85 to 100, 80 to 100. What is normal oxygen in the air? Like what are we breathing right now? It's on the board. Yeah, 21%. Okay? Without any help from a ventilator or any supplemental oxygen, normal FiO2 is 21%. So if someone has an O2 sat, if you put a pulse ox on me, and I'm 95% right now on room air, 95 divided by 0.21 is 452. That's a really good PF ratio. That's greater than 400. When you have some kind of acute lung injury, your PF ratio drops a little bit, right? When you have ARDS, your PF ratio is less than 200. So this is somebody who has only 90% on their pulse ox, but maybe they're ventilated, or maybe we're giving them oxygen through a nasal cannula and they're at 50%. So we're giving them 50% oxygen and they can only maintain an SaO2 of 90%. Then they're only going to be 180. Do you see the difference in that? This is where that refractory hypoxemia that we talk about with respiratory and acute with ARDS, it's a refractory hypoxemia. No matter how much oxygen we throw at them, their O2, their PaO2, is not able to keep up. So you'll have patients with FiO2s of 70% and they're satting 85. What's happening to that PF ratio? It's plummeting, right? Normal is 400. Normal is 400. Acute lung injury. So normal PF is above 400. That means that we can maintain a normal O2 on room air. The more O2 we have to supply them, the lower their PF ratio. Does that make sense?
PF is pulmonary function.
Uh-huh. It's basically it's PaO2 divided by FiO2. FiO2 is room air, or whatever oxygen we're giving them. So the more oxygen we give them to maintain a normal O2, the lower their PF ratio is going to be. That's where that shunting comes into play. That's why we say that it doesn't matter how much oxygen we throw at some of these patients, because we're throwing 70% at them. God bless you. It doesn't change what they're actually getting. Do I need to say it a different way, or does everybody understand that?
The shunting is blocking off
Uh-huh.
all the oxygen you're trying to push out.
Exactly. So it doesn't matter. You keep throwing at them, they're still desatting.
Doors closed.
Mm-hmm. All right. Everybody good?
I got a quick question.
Mm-hmm.
So, seeing all that formula, is it possibility that we may be given these calculations and have to determine whether the person, or whether the patient is in the acute lung injury or ours and/or ours?
You have to understand, in general, that a normal PF ratio is greater than 400. And then if it's not, you need to understand that, like, if you get a patient that you're taking care of, or a test scenario patient, that if you have a patient that you, like, let's say their vent is at 70%, the FiO2 is bumped up to 70%, and you're still satting 85, that should be a clue to say, my PF ratio is really low, something more is going on, I need to treat that cause. Does that make sense? Okay. All right, I'm going to pause the recording for just a second, because I think we're going to run out of time.